join me in welcoming Dr. Flowers, Dr. Margaret Flowers, who is going to tell us how we're going to win healthcare for all.
Thank you. Thank you, Carol. She's a very quick study, so it's been great. Carol's been a great partner in all kinds of activities. So thank you so much for inviting me here to Louisville to speak with you. It's been great. I got in yesterday and had a full day today, and just really wonderful here, and I appreciate all of you that came out tonight. Garrett asked me to do a couple of things. He wanted me to actually kind of give a basic what we're talking about with single payer, so I apologize if some of you already feel like you have a really good knowledge, but I think that it's always good to reinforce that and make sure we all know what we're talking about. So if your eyes start to glaze over, I'll move on, but I think that we should talk about that. And then also I want to talk about the current political environment and how we're going to win this. And so then we'll do some questions and answers. So basically when I started this a number of years ago, and I practiced pediatrics for 17 years, but I started getting really fed up with how our system is, because it's not actually about taking care of our patients. It's the system. I didn't feel like I could provide high quality care under this current system when I was being pushed all the time to spend less and less time with my patients. And so I finally just got fed up and said, well, I've got to do something. And if I leave practice, I'll have the time, and I'll also have kind of a little bit of protection. Some of my friends that were practicing docs were afraid to speak out because they were afraid of retaliation and what the insurance companies would do. And I thought, well, this will free me. They can't get me if I'm not practicing, right? So at the time when I started, the myth that everybody was hearing and believing was that the United States had the best healthcare system in the world. Do y'all remember that? Yeah. And I remember saying, well, we actually don't have the best healthcare system in the world. It felt like people in the United States were experiencing what I call health injustice. You need to get health care, and your first thought is, can I afford it? You need to get your medication, and you have to figure out, well, how am I going to pay for this? What am I going to give up to get that? This is not normal, but I think to a lot of people in the United States, we didn't know that it was not normal because it was all that we knew, and you thought, well, if I can't get the care I need, I did something wrong. I didn't get the right insurance, or I didn't work hard enough, or something like that. But I think that's changed, and people know now that we are different in the United States from every other wealthy nation in the world. That in other countries, people need health care, and they go to the doctor and they get health care. I was just in Toronto. I live in Baltimore. Oops, what's that here? I live in Baltimore, and we have sadly a very high homeless population in Baltimore. And a lot of the people that I see and talk to, when we're out, are very sick people. They have, obvious injuries and illnesses. When I was in Toronto, we saw some homeless people, and not a single one of them looked sick to me. And I said to my friend, we were having dinner, and I said, this is really remarkable. And she said, yeah, they may be homeless, but they can walk into any clinic, and they can get the care that they need. They don't have to worry about that part of it. So I think that people in the United States are starting to get that there is another way, that in many other countries, this is not, it's just the way it is. When you need care, you take it for granted that you get that care. And people want that. I was in a really conservative part of Maryland. We're going after one of our Congress members who hasn't signed on yet, and so we're doing petitioning in all of his district. And we were at this 4th of July parade, and it was a very conservative white working class kind of area. And we would hand the petition to people and say, will you sign this petition? We're trying to get your Congress member to sign on to this single payer bill. And I had so many people that signed it and then said, hey, Joe, you need to sign this. This is like Canada. They're doing like what Canada did. And that was like, and I was shocked because I didn't even know that people had that really awareness that was what we were talking about. So that's changing, and that's a good thing. So what are we talking about when we say single payer? Let's talk about what we currently have. What we have right now is a multi-payer system. Have you heard? 140 different health plans in one clinic, 140 different papers, rules, pharmacy, formularies. This is ridiculous. We have thousands of different health insurance plans in this country, We have the private plans that people get through their employers. We have the plans on the exchange. We have the plans that the veterans get. We have, through the military, I shouldn't say veterans, but, military personnel get through the DOD. We have the plans that, federal workers get. We have Medicaid, and Medicaid itself is not just one plan. There's all kinds of different private Medicaid managed care organizations, and even Medicare is not just one plan anymore. There's all these different private Medicare Advantage plans, and so all of these different plans have different rules, different papers, and so it's a multi-payer system, and it's completely complicated, and it's very hard for patients to navigate. It's very hard for health professionals to navigate. So that's what we have. That's multi-payer. We're talking about simplicity. One of our mentors, Dr. Quentin, always said, oops, are we there? Okay. Always said, focus on, let's see. Okay, maybe if I keep talking right into the middle. Quentin always said, focus on the elegant simplicity of a single-payer system. It's one system. Everybody's in it. We all pay into it, and when we need care, it pays out for that care. That's basically what single payer is. There are different types of single payer plans. Different types of single payer plans. There is what people would think of as a socialized single payer system. That would be what they have in the United Kingdom, their National Health Service, or what we have here in the United States through the Veterans Administration. That's a single payer system where the government owns the hospitals and they employ the physicians. Then we have another type of single-payer system, which we call National Improved Medicare for All. And that's like our traditional Medicare. We pay into it through taxes, and then people can use the system and go where they want to go to get their care. Now, we'll get into Medicare a little bit later because Medicare has some real issues in the United States. It's been under attack for a long time. So it needs some improvement for sure. But if you think about what original Medicare was when it first started, that's another type of a single-payer kind of system. So when we talk about it, we use the terms National Improved Medicare for All. And I think that's the easiest way to kind of frame it when you're talking to other people about it. So it's national. Every single person in the United States, and I don't say just Americans, every single person living in the United States would be in the system. Wherever you go, you're in the system. If you change jobs and you move, you're still in the system. If you go on vacation and you have a health problem, you're still in the system. It's nationwide. It's a nationwide network. Think about if you have an unusual illness and there's a clinic or a hospital in another state that specializes in that illness, it's in your network. You can go there. Imagine what that would be for patients, to be able to go where the best health care is in our country. It's improved. So unlike our current Medicare, it would be comprehensive. It would cover all necessary medical care. So I often talk about body part medicine. I've never understood body part medicine. I've never understood why we say we're going to cover your heart, but not your eyes or your ears or your brain. They're all connected. Did we get that? They all impact each other. If we're going to take care of a person, we have to take care of the whole person, and that's what we're talking about. All medically necessary care, including long-term care, because that's something that is another travesty in our country, that so many people have to go into poverty in order to qualify for Medicaid to get their long-term care covered. We shouldn't have to do that in this country. So comprehensive is improved. The other big improvement is taking away the need for supplementals, taking away the need for deductibles or co-pays, all of these things that are financial barriers to care. So if you have to, you have your health insurance, you pay your premium every month, and then if you need to go to the doctor, you have to cough up a certain amount of money for your copay. Well, immediately, you're making a financial decision about whether you're going to go and see the doctor. And most of us are fairly economically insecure. I mean, the data is there that I think it's 2/3 of people in the United States don't have an extra $500 on hand to handle an emergency, right? So now you're thinking, okay, well, I want to go see the doctor, but it's $25 and, maybe it's not that bad. Maybe I'll just wait a little bit and maybe it'll get better and I won't go. So immediately when money's involved, it becomes a financial decision, and it shouldn't be a financial decision. And in fact, there are good studies that show that no matter what your level of education is,
if you're making a decision about whether you should go, whether you think it's necessary or not, people are just as likely to decide not to go when it's necessary as when it's not necessary. We can't tell. That's why we have, health professionals. They help us figure this out. So, no financial barriers. And then Medicare. It's like Medicare. We pay them through taxes, and the system is there for us, and it's for all. It's for everyone. So, from the time you're born until the time you die, you're in the system. And in legislation I'll go into later that we advocate for, it actually says if you present for care, you're first presumed to be in the system. They just assume, because you've shown up at the door, that you're in the system and you get your care. And then they sort it out afterwards. If you're not in, why are you not in? And how can they get you in, right? So it's very simple. National, improved, Medicare for all. Now, why do we need this? Well, probably you all can give me a long lecture on why we need this, because I think most people are experiencing the problems with our current healthcare system. But just to give you some data, the United States spends twice as much per person per year on healthcare as the average wealthy nation in the world. Twice as much. We're already paying for a universal healthcare system. We're spending twice as much as countries that cover everyone and have better health outcomes than we do. Right? So it's not like when people say we can't do this, that's not true. I could say something else, but it's just not true. We can do this. Why do we spend so much? Well, part of it is the bureaucracy. A third of our healthcare dollars are spent on paperwork. Imagine if that $300,000 was spent on care. That would be huge. But now imagine that we're actually wasting about $500 billion a year on paperwork in this country, and think about what that could do, right? Why is it so expensive? Because we don't have this actual system. We don't have any way of actually setting prices for services or pharmaceuticals. When it comes to pharmaceuticals, they're basically charging whatever they can get away with on the market. It has no connection to how much it costs to make the medication or do the research for the medication. It's what we can get away with. That's how much our pharmaceutical prices are. So we spend the most for drugs, we spend the most for health services. And we don't have any transparency. We don't know what the prices are. And when you're in the emergency room or on your way to the emergency room the last night, you're not really in a position to be like, oh, wait a second, can you go to this other hospital because I see their ER has a lower fee. That just doesn't happen, right? Why else do we need a national improved Medicare for all system? Well, the Affordable Care Act, it had some positive features to it. It did expand Medicaid, and that was where the majority of people got their new insurance, was under Medicaid. Now, we argued that we could have expanded Medicaid without also bailing out the private insurance industry like we did, but we got what we got, right? But the Affordable Care Act was not designed to be universal. In fact, we told people when it was passed that it would never be universal, that it would follow the same trend that we've seen when states have passed similar types of legislation, that there would be an initial drop in the number of people without insurance, and then that would stabilize, and then it would start to go up. And here we are, 8 years later, and it's starting to kind of bump. In 2016, it went up by 4 more million people. Last year, it stayed relatively stable, but the prediction is that we're going to continue to have the number of people without insurance rise. In addition to that, we have something called underinsurance. So underinsurance is when somebody has a health insurance plan, but the actual cost of care to them, based on their premium and deductibles and all of that, is more than 10% of their income. Or for someone who's low income, if it's more than 5% of your income. So these are people who, again, they have the insurance, but they can't afford to use it. I think it was John Yarmouth talked about how we regulated the private insurance companies, and now they're not allowed to deny plans to people based on the pre-existing conditions. Well, Dr. Erickson can attest to this as well. We've learned in our experience that private insurance companies are always ahead of us. As soon as the regulations are being written, they're already figuring out how to do the workaround. And so what they did with the pre-existing condition provision was they said, okay, we have to agree to have people with whatever conditions they have, but we're just going to create these narrow networks and these ultra-narrow networks. I don't know if
we're going to try, though.
Okay. That exclude 70% of the health centers in the community. So if you have an emergency, you've got a 70% chance you're going to go to a facility that doesn't cover, isn't covered by your insurance. All right. How's that? There's a button there. I just have to look. Oh, that's okay. Test? Okay. Great. Much better. Okay. So they got around it. They weren't allowed to drop people based on what their health status was, but they could drop geographic areas. So that's what we're seeing. We're seeing private insurance companies, if they have a geographic area where they're not making money, they just pull out of that money, out of that area. And that's why we've gotten into a situation where in pretty much every state, there's a few health insurance companies that dominate that state. They kind of carved up the country, amongst themselves. So these are all reasons why we need a single-payer healthcare system. And I just wanted to make sure that I didn't, health outcomes. Let's talk a little bit about that. So the United States has a relatively low life expectancy compared to other countries. And over the last 2 years, our life expectancy has been falling. That's the first time that has happened since the 1960s, right? And when there are all these kind of international studies that compare the United States to other countries and look at our life expectancy, what they end up usually concluding is it's because of our system. It's because the United States doesn't have a universal health care system. That's why we have lower life expectancies. The United States is the most, U.S. News and World Report now ranked us the most dangerous place in the world of the wealthy countries to have a baby. Can you imagine that? In the United States, our maternal mortality is like 24 deaths per 100,000 births, and in other countries it's like 5. Right? So we're like 4 or 5 times higher what other countries are. And what U.S. News and World Report did is they started interviewing hospitals to find out why the maternal mortality was so high. And it was due to 2 things mainly: high blood pressure and too much blood loss, hemorrhaging. These are both completely preventable situations. If you have enough nursing staff that are monitoring the blood pressure and the blood loss from a new mother, you can prevent these situations. But we run our hospitals like businesses, and they try to get away with the lowest staffing levels that they can get away with, right? I mean, I fought this when I was in practice. I actually was chief of peds for a while at a hospital and worked out of the maternal unit, and we fought all the time to have enough nurses to be watching over the moms. I mean, when you're having a delivery, that's a pretty precarious time. Things can change so quickly, and you need a nurse in there watching. Anyway, I can digress really easily. Other outputs, outcomes are not that good either. Our infant mortality rates are high. We don't manage chronic diseases very well. We're spending twice as much, but we're not getting a whole lot of value for that. So we need to do something different. So how are we going to do that? Well, part of my journey that I'm still on, when I left practice and I thought, okay, I'm going to get out there and I'm going to fight for single-payer health care because this is what we need to do. And I thought, in my naivety that I was at that time, we're just going to get out there and tell them the truth, and in a few years we're going to win this. Well, then, reality came in. And so part of the work that I've been doing is, how does social transformation occur? How do we win? And that's an ongoing journey, but there's some research that tells us how social transformation occurs. We have 100 years of research looking at social movements and looking at the characteristics that made some movements succeed, more likely to succeed than others. And a major part of that is creating a mass movement, right? And we call it a movement of movements, getting people from all different sectors of the population working together, because how does the power holders, how do they weaken us? Divide and conquer. Everybody heard of that? Divide and conquer. It's age-old, centuries old. Divide and conquer. But if we are a diverse population of people united around the fight for national improvement and care for all, they can't divide us. So we saw this during the Affordable Care Act. We knew that it wasn't going to solve our problem. We were down in DC all the time, and often we were protesting down there. And they're so smart. In the Affordable Care Act, what did they do? 2 really positive, popular things. They said that children up to 26 years of age could stay on their parents' policies, and they improved coverage for women. So when we were down there saying, we need single payer, they were like, what, are you against women? Are you against youth being on their parents' health insurance? You know, what's wrong with you? And I said, no, I'm not against those things, but I'm against leaving anybody out. You know, why are we covering these things but not covering everybody? It didn't make sense. So they divided us against each other, and there were a lot of various groups out there fighting based on their particular interests for the Affordable Care Act. We can't have that happen again. We have to recognize that if one of us is not covered, all of us are not covered, right?
That's right.
We have to be in solidarity. So we have to be a mass movement. And the second thing is, there's three things. We need to have what's called national consensus, which kind of goes along with being a mass movement. We have to have a super majority of people in the United States three things that they have to agree on. One is that we have a problem. I think we're pretty much there on that one. The second is that the current system can't fix the problem. And that was interesting because last year when the Republicans were trying to repeal the Affordable Care Act and the Democrats were saying we have to fix the Affordable Care Act, and we were saying, well, actually we need single payer, people went with us. They weren't saying we want to fix the Affordable Care Act. They were saying we want single payer. So they recognized that the Affordable Care Act, as the benefits that it has, still didn't fix the situation. And the third thing is that they have to have consensus around the solution, being ready for the solution, because most of us are a little bit risk averse, right? It's a little bit scary. We know what we have, it doesn't work that great, but how's it going to be under this new thing? Well, fortunately, we have Medicare in the United States, right? So we kind of know how it works. It's not so new. Back in 1965, it was totally new, but we kind of have it. And we also have a lot of other countries that are doing the same thing, so we know it's not really an experiment. And the one I love is the kind of people that try to convince us that we can't have this. They say, oh, but people don't want to change their insurance. They don't want to give up their insurance. How many of you have changed your insurance in the last 5 years? Right. Yeah. Some people change every year, right? So yeah, that one, when they come at you with that one, just say that's malarkey. So we have to have national consensus around these things, and John Yarmouth kind of mentioned the polls. Well, the polls are pretty exciting because the most recent poll, Reuters, Ipsos, I think it was, found that 70% of people kind of across the board in the United States support a national improved Medicare for all. If you're a Democrat, it's 85%. If you're a Republican, 52%. We have a majority for the first time, and things have been moving in that direction. But now we have a majority, right? And this is essential, because when we pass National Improved Medicare for All, and I believe we will, it has to be bipartisan, right? I know John Yarmouth is a Democrat, and so of course he wants the Democrats to win, and of course he's going to say that they're going to, do the hearings and things, and we want him to do those things, but we don't want it to become a political football. The thing with the Affordable Care Act is that it was a Republican plan, right? It came out of the Heritage Foundation, but it was passed by the Democrats. Not a single Republican voted for it. And so we were down there in DC, and you had the Democrats saying we need the ACA, and the Republicans were saying it's terrible, socialized, government-run, death panels. But what if Mitt Romney had won the election? He had just passed it in 2006 in the state of Massachusetts. What if Mitt Romney had passed the ACA? Then the Republicans would have been, this is our plan, man. And the Democrats would be like, that's not enough. And maybe that would have been a good thing, I don't know. But it was not about policy, it was all about politics. We can't have that. We need a system that creates what we call social solidarity. This is what other countries have learned. They've learned that a welfare system is just that. When you have a system for the poor, it's a poor system. If you want a high quality system, everybody has to be in the system, because then we all have a stake in it. We all want it to be a good system, and we're spending enough money to have one of the best systems in the world, so why don't we do it, right? So that social solidarity is really key. And also, on that note, when we win single payer and we have that social solidarity, I think we're going to see a whole cultural change in the United States, right? For the first time, we're going to have a piece of legislation that says that people are more important than corporate profits. We are going to have a piece of legislation that says no matter who you are, You deserve the same high quality standard of health care as everybody else, right? And it's going to say to us, wow, we've got some power. We just beat back the health corporations. Who are we going to beat back next, right? Let's go for education. Let's go for jobs with living wages. Let's go for affordable housing, right? Let's go for a clean energy future. Let's stop these wars, right? Let's do it, right? We know what we want. We have consensus around so many issues. We just don't understand our power. But this fight we can win, and we will understand our power when we do that. All right, so I've gotten a little off track. Okay, so what's so exciting about right now? John Yarmouth said it. Of all the years that I've been doing it, and some have been doing it longer than me, and I appreciate those who have done it longer than me, I haven't seen this momentum for National Improved Medicare for All in all the time that I've been doing it. Last year, we had groups that we had never really interacted with before that were coming out and saying, we want to work on single payer, we need single payer is our priority. So, and we saw people at town halls all across the country. We have a record number of sponsors on our legislation in the House. People were going to the healthcare town halls last year, and they were saying, we want single payer. In progressive and conservative places around the country. I think in Kansas, was it Congressman Moran that just got chased all around Kansas everywhere he went. They were like, we want single payer. I was speaking at some town halls in Maryland, and got invited to two in very conservative Republican districts. And the first one, there were two other speakers, and they went first, and it was a packed room, and I wasn't sure how they were going to receive me. And they kind of talked about, one was a navigator, he talked about the ACA, one was a family practice doc, she talked about what she's seeing. And then I got up there and I said, well, what I'm advocating for is the National Improved Medicare for All, and this is what it is. Guess what? Standing ovation. Standing ovation in the Eastern Shore, Republican district in Maryland. And then I went to one at the western part of Maryland, another conservative district, and people were coming up during the questions, and they were saying things like, well, what I'm really concerned about is that we're treating healthcare as a commodity, and it's not a commodity. And I was like, whoever says that, right? We say that. But these were people, just common people that are getting it. So the momentum is out there. It's a very exciting time. We have the legislation in the House, H.R. 676, and that is called the Expanded and Improved Medicare for All Act with 123 co-sponsors, the most we've ever had. We don't have a Republican yet, so anybody knows any Republicans? It's your job. Yeah, don't be afraid to talk to them about it, because I actually have talked to Republican Congress members back in 2009, 2010, and I had people tell me behind closed doors, you know what? If this actually came to the floor, I would vote for it, because I get it. I understand when you put everybody in one single pool, it's much more efficient, it's much more cost effective, but my constituents are not there, and I can't vote for this because they're not there, right? So, but that's changing. We have a bill in the Senate. Senator Sanders introduced it. It's called S1804. So we're glad that that bill is in the Senate. It does have a lot of very serious defects that need to be fixed, but it's there, and that's a good thing. And it's a good thing that all of the members of Congress and the Senate who are thinking that they're going to run for president on the Democratic side felt like they had to sign on to it, right? That shows that we're building momentum and that we're building power. But let's get back to the House bill, because the House bill is really our gold standard. And the House bill is based on something called the Physicians Working Group proposal. It was written in 2003 by a group of physicians from PNHP, Physicians for National Health Plan. And that was updated a few years ago, so if you go to pnhp.org, you can read that. That is a plan that was written by people who understand health policy, who wanted to design a health system that would actually work, right? So it contains all of the essential ingredients that we think are necessary. And that Congressman John Conyers had introduced that every session since 2003. He was very faithful partner to the single payer movement, and he listened to us, and he made sure that it was a strong bill. Now, Conyers left the Congress last year, and then Keith Ellison came in as the lead sponsor, and then Keith Ellison left the Congress. So we have a new sponsor, Pramila Jayapal from Washington State. She's a relatively new member of Congress. And just to be honest, we're not confident that Congresswoman Jayapal has the same allegiance to H.R. 676 that we had in John Conyers. And so We understand that she's reworking the bill right now. Sadly, we don't know what the details are of that reworking. What we're hearing makes us concerned. So one of the tasks that we have is to actually make sure that our members of Congress, that all of them understand that we have a line in the sand. You know, there are certain things that have to be in this bill. It has to include everybody. It has to be comprehensive. It has to get rid of the co-pays. It has to get rid of the for-profit institutions. It has to cover things like long-term care. It has to get rid of, there's payment mechanisms in the Senate bill that are driving doctors out of practice, but that's a really wonky thing, and I don't want to get into it because it's confusing even to me. But, so we have to be really strong, and this is where we get to, you know, as we're building momentum in this fight, we're taking on some pretty powerful power holders, taking on the health insurance industry and the private hospital industry and the pharmaceutical and the medical device companies, right, who are all profiting so amazingly off of our current system, disgustingly off of our current system. They don't want to let go of that. And they have a lot of power over our members of Congress because they fund their campaigns. They have all kinds of lobbyists who go into their offices and talk to them. So we know, because we know how social movements work, that as we build power, or we see from the Center for American Progress the Medicare extra for everyone, right? But these things are not the same thing that we're talking about, right? These are false solutions, they're insufficient solutions, whatever you want to call them. They're things like what we would call public option. And I know people were excited about the public option back in 2009, but the reality is the public option doesn't change our healthcare system. It adds another health insurance into our healthcare system. It adds another public health insurance into our system. It maintains all the complexity, all the expenses. To think that a public health insurance plan is going to compete with these private health insurance plans is kind of, that's fantasy, right? That really is. You know, we know that they can't compete. We know these private insurance plans, they've got the marketing, they've got the money, they can run rings around these public plans, and we see that in Medicare. We see it with the Medicare Advantage plans. The Medicare Advantage plans, which are what the private insurance companies sell, attract the healthiest seniors. They're really good at that. And then when seniors get sick, guess what happens? Well, then they find out that those plans are private insurance plans and they have restricted networks and they aren't going to cover everything. And so the seniors leave those plans and they go back into the original plans. So they're really soaking us. The Medicare Advantage plans take more of our federal dollars than the original does per person. They cost more, and they're taking care of the healthy population. So our sicker seniors are in the original Medicare that's being squeezed without the same amount of dollars. So there is no competition there. So a public option, you know, a buy-in to Medicare, whatever you want to call it, is not going to solve our problem. And we need to make sure our members of Congress understand that. Then the other idea we hear is, well, we're going to lower the age of Medicare. And to the average person, that probably sounds like a great thing, right? Oh, okay, well, we'll lower it to 55, and next year we'll lower it to 45. But the reality is we don't have to do that. There's no reason why we need to do a graduated lowering of the age. We could decide next year that we're going to cover everyone. We're already spending the money. We already have the infrastructure. It's really just an excuse to delay it, and it keeps, while we're lowering that age, for everybody else, it keeps that multi-payer, complicated system in place, that expensive system in place. And so you're going to start covering more people under Medicare, but where are you going to get that money when you're not getting any savings because you're still having to pay for all this mess and all this administration and the high prices because you can't control them? When I talk about it, people say, well, you have to be incremental, right? That all about politics is like taking steps. We have to do incremental change. Reality is that in this country, our healthcare system needs a lot of work. The smallest step that we can take is to move to a single-payer system, because that means we get everybody in it, we get the profit out, we have the savings to cover everyone, right? And then after that, guess what we got to do? A lot of health planning, because we're losing our hospitals, especially in low-income and rural areas. We need to build those hospitals, open them back up. We've got to build up our primary care workforce. We don't have enough primary care doctors, and that's the backbone of a good health system. In the other countries, they have twice as many primary doctors as specialists. We are on the flip side. And why is that? Because, well, it's because medical students, you know, when I went to medical school, I went to a public medical school, University of Maryland. I'm, you know, single mom, 5th child, worked my way through college. I was able to go to school. It was $5,000 a year for me to go to medical school. I came out of school with, some debt, I think $30,000 or $35,000, but I was able to pay that off over time. Students are coming out of school with debt now, $150,000. That's like having a mortgage on your head, right? With no house, right? So what do? They gravitate towards the specialties that are going to pay them enough money that they can actually pay off that debt. And who's going to medical school? It's the people that can afford to go to medical school that are going to medical school, right? So are they going to be likely to go into underserved communities in rural areas? No. So we need to address that issue as well. That's another whole thing that we need to do once we win single payer. Make sure that we're training our doctors and that we're training all kinds of doctors and making sure that we're getting them, where we need them, and nurses and physician assistants and all, social workers. We have a great need in this country for all kinds of people to provide direct care. Now I totally got off track. All right, let's see. So the last thing, two last things. Okay, two.
Margaret.
Yeah.
Margaret, try standing at the other corner.
Okay, all right, let's see. All right, so one of the other things that they're going to try to do is they're going to try to water down the legislation. So that's kind of what we're worried about right now with HR 676. But we're also worried, and we're kind of hearing inklings of this, is that Medicare for all, to some of our members of Congress, means our current Medicare, right? The current system with the private plans and the public plan. And we're talking about a single system that's just a public plan and getting those private plans out. So we have to make sure that it's not Medicare Advantage for all that we want, it's Medicare for all. And then finally, I just wanted to share with you the lesson that I came away with when, okay, wait, one more quick thing. In addition to national consensus and a mass movement, guess what percentage of the population we need to mobilize to win? Throw out a number. What percent of the population do you think we need to have out there protesting? That's a good guess, 3.5%. If we mobilize 3.5% of the people, if we get out there actively fighting for this, we will win. No movement has ever lost when they've mobilized 3.5% of the population. They've won with less, but with that, they've always won. So we always feel like this is so impossible because we need to get everybody fighting for it. No, we need to get mostly everybody to agree that it's the right thing to do, and then we need to get a small percentage of the population activated on. Okay, now the last thing. When I was Congressional Fellow in 2009, 2010 for PNHP, so I was in Congress pretty much all the time, sometimes testifying and sometimes rabble-rousing with my friends. I came away from there with three kind of lessons of what we need to do if we want to win, and I used the initials ICU. And you can think of it, okay, we have a healthcare crisis, we need the ICU, intensive care unit. I didn't actually think about it in that order when I first did it, but it works. So I is for independent. We need to be independent of political party in this fight. We cannot attach our agenda to the agenda of any political party because that's what happened in 2009. It became all about the legacy of the Democrats, and as the bill got weaker and weaker and weaker, members of Congress told me, I have to hold my nose and vote for it because this is our legacy, right? So we have to recognize that no matter who's in Congress, we have to do our work to build a movement and to pressure them, so independent. C stands for clarity. They're going to try to fool us with all kinds of things, Medicare extra, and choose Medicare, and better Medicare, Medicare, super special Medicare. We have to know whether it's actually Medicare that works or not. Does it meet our criteria? Is it a single-payer system? Does it cover everybody? Is it comprehensive? Does it get rid of the financial barriers to care, right? Does it kick the for-profits out that are just, sucking money out of our system to give to their investors and their CEOs, right? Why would we pay them? Why do we need to spend our public dollars on investors' dividends, right? When we should be spending it on healthcare. So we need to be clear, because the public option was used to fool people. People were told that it was a backdoor to single payer, and that it was going to compete with private insurance, and we knew it was neither of those. But people got fooled by that, so we can't get fooled again. And lastly, the U stands for uncompromising. Throughout history, people in social movements have been told that they're asking for too much. They're told you have to compromise. Politics is about compromise, right? Has anybody ever heard that before? Politics isn't even compromise, right? No.
when they say we have to compromise, they're trying to take our power away. There's some things you can compromise on, right? Like if we're talking about wages, maybe we could compromise on how much we're going to negotiate in our wages. But when it comes to human rights, when it comes to life and death, when it comes to suffering, no, there's no compromise there. Everybody needs to be in the system, right? And Gandhi said this. He said, when you're talking about fundamentals, you can't compromise because it's all give and no take, right? It's all give. When you're talking about the basics, when you compromise, it's all give and no take, right? So, uncompromising, clear, and independent in our fight for national improved Medicare for all. This is the time. We are winning. We see the signs that we're winning. So let's keep it up. I'm so glad that you're all here, and I look forward to answering your questions. Thank you.